Spondylosis may be applied nonspecifically to any and all degenerative conditions affecting the discs, vertebral bodies, and/or associated joints of the lumbar spine. 1. Low back pain (LBP) affects approximately 60 to 85% of adults during some point in their lives. Spondylosis. Not a clinical diagnosis but instead a descriptive term utilized to designate spinal problems. Encompasses numerous associated pathologies including spinal stenosis, degenerative spondylolisthesis, osteoarthritis, aging, trauma and just the daily use of the intervertebral discs, the vertebrae, and the associated joints, too. The lumbar region the most affected, because of the exposure to mechanical stress. Lumbar spondylosis is a complicated diagnosis. Easy to identify radiographically, its pervasiveness throughout all patient populations makes the exact diagnosis of symptomatic cases extremely difficult. 85.5% of individuals aged 45 to 64 years demonstrate osteophytes within the lumbar spine. Degenerative changes may appear in young individuals without no trauma history. Spondylosis, degeneration of the lumbar spine, generally initiates from the intervertebral disc which cause progressive biochemical and structural changes to take place, leading to a modification in the physical properties of elasticity and mechanical resistance. Disc lesions cause pathological changes in the vertebral bodies, where osteophytes appear. Most osteophytes are anterior or lateral in projection. Posterior vertebral osteophytes are less common and only rarely impinge upon the spinal cord or nerve roots. Patients with lumbar spondylosis have pain in the axial spine. The location of these degenerate changes is not surprising as nociceptive pain generators that were identified within facet joints, intervertebral discs, sacroiliac joints, nerve root dura and myofascial structures. These changes may peak in different clinical presentations such as spinal stenosis, disc herniation, bulging of the ligamentum flavum, spondylolisthesis, lumbar radiculopathy. All the above result in a constellation of pain symptoms encompassed in the term neurogenic claudication (NC). It may include, to varying extents, lower back pain, leg pain, as well as numbness and motor weakness to lower extremities that worsen with upright stance and walking, and improve with sitting and supine positioning. Clinical presentations of radiculopathy may emanate from spondylosis, all of which can be explained by the degenerative process. E.g. hypertrophic changes to the superior articular process may intrude upon nerve roots within the upper nerve root canal, dural sac, or prior to exiting from next lower intervertebral canal, depending on their projection. General examination of the spine. Inspection of the entire spine. Look for any obvious swellings or surgical scars. Assess for deformity, scoliosis, kyphosis, loss of lumbar lordosis or hyperlordosis of the lumbar spine. Look for shoulder asymmetry and pelvic tilt. 2. Palpation. Palpate for tenderness over bone and soft tissues. Perform an abdominal examination to identify any masses and consider a rectal examination to exclude other pathologies in this region. 3. Movement. Flexion, extension, lateral flexion and rotation. Examination of the spine must also include examination of the shoulders and examination of the hips to exclude these joints as a cause of the symptoms. 4. Neurovascular examination. Sensation, tone, power and reflexes should be assessed. All peripheral pulses should also be checked, as vascular claudication in the upper and lower limbs can mimic symptoms of radiculopathy or canal stenosis. Physical therapy management. Educating the patient may include reviews of lumbar anatomy, explanations of the concept of posture, ergonomics and giving appropriate back exercises. 12-13. See interventions for LBP. Manual therapy techniques for the lumbar spine. Mackenzie method. Massage. TENS. Other modalities include lumbar back support, can be beneficial for patients suffering from chronic LBP. It occurs to limit spine motion, stabilize, correct deformity and reduce mechanical forces. There is no consensus if it may function as a placebo or really improve pain and functional ability. Level of evidence 1A. Sitting decreases lumbar lordosis and increase disc pressure, squeeze on the ischium and muscle activity in the lower back. These are all associated with low back pain. The study of Mixu et al. resulted in a diminished lumbar spine load and lumbar muscular activity with lumbar back support. This may possibly lessen low back pain while sitting. Taping, another non-surgical management, could be taping. A lot of studies have shown that taping helps to relieve pain in the lower back. This tape could be standard tape or kinesiotape, as it is shown that there is no difference between both tapes. It is also important to note that taping alone is not enough. It should be used during the therapy to improve ROM, etc. Lumbar support with the help of braces are used for stabilization and reducing mechanical forces. They are also produced to limit spine motion and correct deformity of the spine. There is limited evidence-based research available about the efficacy of lumbar supports regarding patient improvement and functional ability to go back to work. An example of a brace for lumbar support is the Lyon antikyphosis brace. This brace has the best results for patients with scoliosis but can also help patients suffering from lumbar spondylosis.